Well, I'd like to welcome you all to my presentation about Ebola. It looks like several of you in the healthcare field are interested, and so this talk is actually going to have a little bit more information in it than my first one, which was designed more or less towards the general public. So this will have a little bit about PPE, which I did not have to the general public, and also about how actually Ebola causes symptoms, which I did not provide to the general public. Now I see that there's some people in the audience that look like you might be general public type of people. Are you actually professors here at the college, or you, for example?
No, I'm not. I'm a student, but I'm also CNA and used to be an advanced EMT.
Okay, good. A lot of these people I recognize because they took my class, so that gives them a little bit of an edge. But you, sir, where are you from?
I'm a student also, believe it or not.
Yeah. And your interest is, just out of curiosity?
Well, I think everybody's interested in this.
Okay.
It's in the headline.
Yeah. So this one has a little bit more educational material on it directed for the students. So I hope that you will find it useful. Let me go ahead and show you what my goals are with this talk. I hope that after this talk you will be able to understand what Ebola is and why is this current Ebola outbreak so bad, and how you get Ebola, what are the symptoms of Ebola, how is it treated, and then also I'd like to do an assessment of the healthcare system's initial response to Ebola. Then also at the very end, what can you do to protect yourself? And so this is going to be a little bit longer because it will go into PPE, or personal protective equipment, than my first talk did. So let's go ahead and first get started. And I'm still going to keep things pretty simple, yes. I'm actually recording right now. So it'll be on the A&P website. So questions and stuff, I'll try to remember to answer questions as they come along, but also repeat the questions so that as you listen to this talk later on that you'll know what was said. But yes, this talk is being recorded right now as we go along. So first off, Ebola is a virus. And so remember, I started this for the lay public, and a lot of people really don't have an understanding of what a virus is, and I think you all will agree with me. Viruses are incredibly small, nanoparticles here. People have heard of nanotechnology, and it's really kind of hard to wrap their head around, but they know they're really, 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 really small. And so these guys are the size of nanometers. And to explain things to people, you need to indicate that viruses have genetic material in them. And the genetic material is either in the form of DNA, which is what we actually have for our genetic material or our blueprint of ourselves, or in the form of RNA. So viruses are either DNA viruses or RNA viruses. Then a virus has around it a layer or a coat, and this layer or coat is made up of protein. And proteins like what most people are used to, eggs, protein, meats, protein, things along that line. But then viruses have a capsule around that. And it's this capsule's presence or non-presence that actually determines the hardiness of a virus. And when I say hardiness of a virus, its ability to actually survive outside of a live host. And so with Ebola, Ebola has a capsule. And at first you think a capsule will actually make a virus hardy, but having a capsule makes it less hardy. So capsulated viruses are less hardy. In other words, they're able to survive outside of a living host less well than those without a capsule. And at first it doesn't make sense until you get into virology, and none of us are going to go that deep into virology. But Ebola has a capsule, and so therefore it is less hardy. So it cannot survive for a long period of time outside of a living body. The other thing about viruses are cellular parasites. So they need a cell, a living cell, in which to invade. And cells have on their surfaces things that viruses actually can recognize. And when a virus recognizes certain things on a cell surface, that means that the virus can land on that cell and actually invade that cell. And when it invades that cell, then the virus is then able to survive and reproduce. So a virus needs a cell in which to really live. And to really live, I mean that is to actually reproduce and propagate itself. Because the cells are actually what most people that have taken science courses know, that the cell is actually what the virus hijacks to make more virions. And so one of the things about viruses have been around for a long time, long time. and they need living cells in order to live. So destroying the host, I know that flashing light's annoyance. Destroying the host is not really a good thing for a virus. But viruses can destroy their host. And unfortunately, that's what Ebola does when it lands inside a human host. There are other hosts it lands inside, and it doesn't do that too. And we'll talk about that because part of the Ebola reservoir are actually fruit bats in Africa. So Ebola in our cells gets into our cells, hijacks our cells, and uses our cells as a method to get around our bodies, to get into tissues to where it then will rupture the cell, cause the cell to lyse or rupture, and then spread more of the Ebola virus in the area that it lands up. And so that's the bad thing about Ebola. Why it does this to us, I cannot tell you. I'm not a virologist. I'm just trying to tell you that this is actually the mechanism of transmission. The other thing that most people don't know is all of you right now have anywhere from 2 to 17 different viruses in your system right now. And so your bodies were actually designed to survive these viral assaults. And that's part of what your immune system is all about. So we have all these viruses. They're all around us. People are coughing and sneezing, you know, vomiting, diarrhea. Those are typically a viral process, and we get assaulted by these viruses all the time. They get into our systems, and depending upon the ability of our system to recognize them or have already seen them, we'll be able to fight it off without even realizing that we actually have been invaded by these things. But if you've had chickenpox, naturally, the chickenpox virus is still in you. If you've had fever blisters, that herpes virus is still in you. So there are viruses in you all the time that stay because it's to their benefit to stay and preserve the host and just manifest themselves periodically to spread, because that's what they do. The types of cells a virus infects will actually determine the symptoms presented by the individual. And so that's one of the things that we'll talk about when I talk a little bit about the pathology of Ebola, how it actually spreads and why it causes its symptoms. One of the things about Ebola belongs to a family of viruses that cause viral hemorrhagic fever. So there's a whole group of 30 different viruses out there that cause viral hemorrhagic fever. Ebola just happens to be a member of that family. And so when you take a look at this list is not something for you to memorize or anything at all like that, but it's for you to actually take a look here and see, do I recognize any of these names when I look over here? Do I recognize this? Do I recognize this? Do I recognize hantavirus? So hantavirus belongs to the same family that Ebola does, but hantavirus is spread by a different route. Okay, here in the United States, hantavirus, its host is the rodent or mice or rats. And its fecal material can harbor the virus for a long time. And so it's whenever people are cleaning out their garages or things along that line that they're actually exposed to hantavirus. But hantavirus is much more common for our experience level, and hantavirus can be completely lethal, or it may not be lethal, depending upon the supportive care and recognition by our healthcare system for the individual that has that. But that's what's important for you. Hantavirus is actually even a member of this. Now, Ebola is a member of this group of 30 here, and they call it filovirus because it looks filamentous. And that's the picture of Ebola. This is one of the very first pictures of Ebola that was ever taken. And Ebola has 5 different members to its own family. Marburg's an awful virulent one also. But the rest of the stuff, yellow fever, you guys have heard of yellow fever before. Those are all part of a group that cause viral hemorrhagic fevers. And the hemorrhagic portion, it can be actually quite variable. It just depends. And you've probably already heard of dengue fever. You know, dengue fever is actually in the United States now. You guys realize that. It's actually made its way up into the southern United States. So these things are already here. It's just that we aren't aware of that because we live in the northern climes where we have other issues to worry about. Because in our area, in our climate in the northern area, you know, we have more of a concern about MS or something along that line. And so those are the things that we pay attention to because that's our risk profile. And that's what's important about Ebola here. The one thing, too, I want to point out to you about this Ebola virus, Ebola was actually discovered in 1976 And it was an outbreak along the Ebola River in Zaire. And that's why they call the first Ebola that was ever discovered Ebola Zaire. Well, these blood samples were collected and were sent to the CDC lab. And what was fascinating is when they got to the CDC lab, they opened up the container, they were all broken. And so the lab person tried their best to harvest what they could because they were wrapped up in cotton and stuff like that. But there's all this bloody cotton and broken glass inside. Tried to harvest some smudge smear of the bloody material and put it on monkey cell cultures. And noticed in a few days the monkey cells looked really, really sick. And so then they actually took it out and prepared it for its first electron micrograph. And so that's what you see here. So Ebola came here to the United States to be looked at and was for the very first time ever seen and then ever named back in 1976 at this lab based upon broken samples. So I want you to realize this person never got sick with Ebola. And they were observing normal standard lab protocol. And the other thing, too, is remember, Ebola is not airborne. You know, hantavirus can be airborne because you're mixing up the fecal material in the air when you're out in the garage and stuff like that. But Ebola is not airborne. And so that individual was quite safe as long as they were observing standard CDC lab protocol. And lab protocol is important that everybody observe in order to be protected from these things that can be actually very lethal to us. What you don't know, or maybe you do know, there are 5 different strains of Ebola out there. The first 4, Ebola Zaire was the very first one discovered, and the blue shows you that it had almost a 90% mortality rate. Then Ebola Sudan, Bundi Bugyo, that's the best I can do, and Typhus and Ruston. And if you notice, the lethality is going downward as we go across this graph. And so this is mortality rates in human beings. And Ebola Zaire was the very first one discovered. Zaire, which is now the Republic of Congo, and by the Ebola River. So that's how it actually got its name Ebola, because of the river. But Zaire was where the first specimen came from. Then Sudan, Bundibugyo, Typhus, and Ruston. What's important about these is you can see that some of them are more lethal than others. The other thing that's important, Ebola Ruston is not lethal to humans at all. It's lethal to monkeys and chimpanzees. And all of the others, the first 4, all come from Africa. And as far as frequency of outbreaks, as you go across, there's less frequent outbreaks of the less virulent ones. The Ruston one, though, is a very interesting history because these were monkeys that came from a supplier in the Philippines. And this Philippine supplier gave monkeys to primate labs. And so we have primate labs in special areas to do testing to make sure that it's okay to use this material or this medication on monkeys. And then if it's safe on monkeys, then we can actually see about doing human trials. And I actually prefer to find out it's safe on another thing before I find out it's safe on me. And so this is a very normal thing to do, to actually test things out on primates. Well, this primate lab got these monkeys in from the Philippines, and those monkeys started dying left and right. I mean, they were just having horrible, painful deaths. And it was running through the facility like wildfire. And so what they did, the government actually came in and euthanized all the monkeys and destroyed them. And they had to do this because they didn't understand the method of transmission. And some people actually think that the method of transmission was airborne. But I'll tell you what, I'm pretty sure I know what the method of transmission was. And you read a lot of the stuff, and it will not tell you all the answers to your questions because you should be able to connect the dots and put things together. And this is what I put together with Ruston. Ruston was lethal to primates, to all these monkeys here. And as far as we know, 100% mortality rate. We killed them before we could actually verify that. But, you know, they were dying painful deaths. And what's interesting, all of the handlers, they seroconverted. None of the handlers developed Ebola symptoms. None of them got sick. None of them displayed anything was going on with them. But when you tested their blood, they all developed antibodies to Ebola Ruston. So that Ebola strain is lethal to primates, but not to humans. and as a matter of fact doesn't cause any of the disease in humans that we know. But it's there in the system, and the cells of the humans are able to keep this form of Ebola at bay and not even be recognizable. So this is what's interesting about that. And when you think about that, how do you think that all those monkeys got sick? If all those handlers had Ebola in them, then it's easy enough to be thinking, I'm fine and I'm handling the monkeys. And so most likely the method of transmission in Reston was actually from the handlers. You know, and it wasn't that they weren't observing reasonable precautions, but I wasn't there, but that actually makes the most sense. Handlers didn't get sick. They didn't know that they were carrying it, and they were taking care of the monkeys, and the monkeys were dying like wildfire. And so we just went in and said, we're getting rid of this. We don't know what the heck's here, and that's going out. And so that's a little bit of that history of the various Ebola infections that we know about. The other thing is Ebola has to survive in between epidemics, and it does so in Africa in the fruit bats. And so that's what this picture is here for you. It is here to show you this is the reservoir. This is the host that Ebola can live in just and survive in and do its little deal without killing the host. So the fruit bats get infected with Ebola. They spread it to each other because of their saliva, because Ebola requires fluids. Any form of fluid it requires in order to be transmitted. And so these bats are spreading it to each other. Ebola's in their guano. And so anything that comes into much contact with their bat guano or their fecal material has a chance of getting it. But also fruit bats eat fruit. And one of the things that they do is they get some fruit and they take a chunk out of it, and they got all this infected saliva, and then they drop their fruit, and other animals come along eating this fruit that has been infected by fruit bat saliva. So the fruit bats are the reservoir or the host that actually keeps Ebola alive, and they don't die from it, but they continue to harbor it. And then what happens is they actually have a little antelope over there that actually gets Ebola also, and any of the primates, monkeys, chimpanzees, gorillas, all those guys actually get Ebola and they die from it. So the primates are dying from the Ebola. But the other thing too is these other animals are getting it, and humans are getting it because of either their contact with fruit bats, because they're playing with fruit bats or something along that line, or their contact with these animal vectors. And so in Africa, you know, they have different traditions than we do. And so they'll eat these creatures. You know, they'll eat the primates, and they'll eat the little antelope. The Ebola even infects porcupines over in Africa. So these other animals are getting Ebola from the primary fruit bat, the reservoir, and then they are the ones that are spreading Ebola to the humans. And we'll talk about how they spread Ebola to the humans in just a moment. This Ebola outbreak, Ebola outbreaks have been going on since 1976, since it was discovered, and probably before that. But it was 76 when we first gave it a name and therefore gave it some identity. And so since that time, there have been over 25 Ebola outbreaks in Africa. And they have been able to contain them and keep them relatively small because of where the outbreaks occurred. This outbreak is occurring in a totally different area than the previous Ebola outbreaks. This area started in Guinea. Started in this little area of Guinea, and this little area of Guinea is right next to the borders of Sierra Leone and Liberia. And so what happened is, first recognized patient with this that was able to transmit the disease was in an area of high traffic. In all of the other outbreaks, these were more rural areas, and it was easier to isolate and quarantine these people that were having these outbreaks and convince them of changing some of their typical habits that they had when they were caring for the sick or for the dead. But now we are in a very highly populated area where there is a lot of political instability and poor infrastructure as far as healthcare goes. So you don't trust the government. That's what political instability causes for you. You don't trust the government, and your healthcare is understaffed and under everything. under budget. You know, there's not enough places, there's not enough people, there's not enough materials, there's not enough anything to take care of you. And so it started in this area and was able to easily spread across the borders into these other very populated areas. And the other thing, too, the reason that this outbreak was able to do this, it was in this area that had never seen Ebola before. Africa's a big place. And so this is West Africa where this outbreak occurred, and they had never seen Ebola before. And so when it showed up on their doorstep, they didn't recognize it. And we already know what happens when you don't recognize Ebola when it shows up on your doorstep. The typical transmission rate that we experienced, they have already experienced way long before we did. For every Ebola patient, 2 will become infected. Okay? So they already knew this. Okay? We have found this out already, and we've verified their findings, I guess, is a way you can look at it. But they didn't recognize it, they couldn't, and they didn't, therefore they didn't act on it fast, and they didn't have the resources to act on it. And they have a lot of mistrust. And so it was able to spread to actually where, as of October the 12th, these were the stats. Senegal had a case but no deaths. Nigeria had 20 cases and only 8 deaths. And Nigeria and Senegal now have been declared Ebola-free as of a couple of days ago. Guinea is having at least 50% of a death rate of those infected. Sierra Leone is not quite 50%. And then Liberia, which is having the largest number of cases and also a very high mortality rate, has at least a 50% mortality rate from Ebola. So we are in areas where they're having a hard time containing them. And this is really, really bad. These infections are increasing. They're expecting, 10,000 more infections over the next month. So that's a pretty remarkable number, and even much higher. I'm actually downplaying it. So how do you get Ebola? You have to have direct contact. Key, direct contact. You must touch them. It's not the air that they breathe. It's not the water or the food that you can get Ebola in, unless, of course, you're eating fruit that have been munched on by fruit bats in Africa. You're not going to get it via these vectors, these routes. So you have to have direct contact with body fluids of a person who is sick with Ebola or who has died from Ebola. And the reason that this is important, because this is one of the unfortunate methods of transmission over in Africa, because their death and burial practices are very different from ours. They, as a family, when somebody dies in their family, they wash them. They wash them and they prepare them for burial. The family does. They don't wear, and these people, do you think these people have nitrile gloves handy, as they're doing these things? And so this is why this is one of the main methods of transmission, because they are washing them. And the very sweat on that person's skin is infectious. A dead person is to me like who died from Ebola is like an Ebola bomb sitting right in front of you. And so this is what's important. A person, direct contact with body fluids of a person who is sick with or who has died from Ebola. So anything that you can think of, sweat, saliva, tears, snot, vomit, diarrhea, blood. What about breast milk? What do you think? What about vaginal secretions? What do you think? And what do you think about urine? It's in the urine. And what do you think about the semen? Oh, yeah. They have actually found Ebola virus living in somebody who has recovered from Ebola, living in the semen 82 days after disease. Okay? So it has a high survival rate in certain types of fluid. And so one of the things that the CDC recommends is condom for 3 months. I say 6. What do you say? I say, oh, let's do the abstinent route. There's some other way. Okay? There's some other way. I'll see you in 6 months, honey. You're going off to, you're going someplace, not Liberia. You're going to Alaska or something like that. So,
Yeah, because that's 100% effective.
Correct. And so, well, because, yeah. And so we'll talk about the suits. The suits, there was nothing wrong with what the nurses had done. And I want to stress that. It was the protocol sucked. Okay? And you'll see why it's easy for me to say that the protocol sucks, because we're going to take a look at what they wear in Africa and what we were wearing, okay? So any secretions, any fluids generated by a person is considered infectious when they're sick. So what about before they become sick? Well, you know, the virus is mounting up its infection, and it's not really able to seed all these areas very effectively in the beginning. But once you develop a fever, or on the pathway to developing a fever, you know, you're off limits. You know, it's like that little vampire cross that you stay back and don't get close. A meter is fine as far as I'm concerned. And it's true. You can actually be a meter away from a sick person and you're going to be fine. Okay? Because it's not transmitted in the air. Now, if they cough in your face, that's called spit in your face as far as I'm concerned. So that's another method of transmission. But ordinarily, respiratory symptoms are not a hallmark of Ebola. I'm not saying that you can't have them. It's just not a hallmark. So objects contaminated with the virus. Well, that's the other problem. When you don't have a lot of money, what do you suppose you do in a poor country with needles? You reuse them. And that's an unfortunate thing, because you're going to the healthcare to get treatment, and you might end up getting a disease from these areas instead of actually the cure. And so they reuse needles, various medical equipment, contaminated clothing or surfaces. And see, this is important, because this is where people get nervous about in Dallas or in New York. It's how much and what type. Okay, so somebody with Ebola coughs on their hand and then opens up a door. Well, Ebola, what's interesting about Ebola, it's not a hardy virus. It is subject to viral death upon desiccation and ultraviolet light. Okay? So if you leave it alone, it will die naturally. Or if it's exposed to the sunlight, it will die naturally on those surfaces. And so it's not hardy, and so you can kill it by just letting it dry out or applying ultraviolet light to it. There's other things that you can do to kill it, and we'll talk about that in just a moment. But it will be on a surface depending upon what, you know, if it's sweat, like a sweaty palm on a doorknob, it'll be on that surface for a few hours, okay? But if it's somebody had bloody diarrhea or bloody vomit, and you wrap it all up, it'll be there for about 6 days. So it depends upon volume and material, okay? So that's what's real important about that. The other thing, too, is infected animals. So you don't want to come, you know, you don't want to play with fruit bats in West Africa, you know. You don't want to eat the monkeys or eat the antelope, you know, that are in an area where Ebola is actually breaking out. The thing is, though, they do. I mean, they eat bushmeat, and that's what the bushmeat is their monkeys and stuff like that. And sometimes, you know, I wouldn't be surprised if they eat what my equivalent is to roadkill. We have people that eat roadkill, you know, and so bushmeat, roadkill, you know, they have no idea why the animal is dead, and they're going to eat it. Oh my gosh! But you know, that's not our culture, you know, and that's not what you guys have grown up with. The other thing too is dogs. Dogs don't appear to exhibit any symptoms of Ebola. But when they've gone around in areas where there's been an Ebola outbreak and they actually check the dogs have seroconverted. They actually have developed antibodies to Ebola. So yes, dogs get infected with it, but dogs are asymptomatic. They exhibit no symptoms of Ebola. But does that mean that you can trust them to be a safe reservoir? And so there was a bit of a stir over the lady in Europe. Her dog was euthanized. Yeah, you know, and they were trying to get, you know, the rabble roused and save our dog, save our dog. I'm going to kill the dog, kill the dog. You know, I'm sorry, you know. I don't know about you, but dogs like to lick your hands and your feet, and, you know, they're always trying to lick something, you know, and you just don't know if it could be a asymptomatic reservoir, do you? And do you really want to find out? And so that's why sometimes we don't find the answers to some of these questions, because, you know, I'd rather take the short-term answer than find out long-term that, you know, I have now a couple more infected people that I have to take care of because my dog infected them. And so that's one of the things that you have to realize, is that, yes, in Africa, their wild dogs do have actual antibodies against the Ebola. So that could be a reservoir, couldn't it, over in Africa, unbeknownst to a lot of them. So I hope you understand you don't get Ebola from air. You don't get Ebola from water. It needs something living. Water is not going to cause it to live. And you don't get Ebola from food, the way, we eat. Okay. So incubation time for Ebola is anywhere from 2 to 21 days. The sooner you get it, the worse you're going to be, the worse your prognosis. So 2 to 21 days, and they're recommending for anybody that has had any sort of exposure to people with Ebola, monitor their temperature twice a day for 21 days. Now, there are always going to be outliers. You guys know what outliers are, right? Somebody that doesn't follow the rule of 21 days. But they're few and far in between. So that's why we can feel reassured about the 21-day time frame. So somebody showing symptoms at 28 days, that's going to be really, really unlikely. I'm not going to say impossible, but it's going to be really unlikely. 21 days is pretty much your safe harbor, your safe window. And they want you to monitor your temperature twice a day because that's something easy to do. It's something that you can write down and you can document. Documenting whether or not you feel tired one day to the next is harder to do because we'll go over symptoms of Ebola. But temperature is easy to document. And so that's what they'll actually use. But do 100% of people with Ebola have a high fever of 103? The answer is no. So you have to also realize you do have to take a look at the temperature log to look for a consistent temperature elevation that is actually maintained. So here are the symptoms of Ebola. And they typically occur the actual time that the majority of symptoms when people are infected with Ebola, when they have their symptoms, is anywhere from 8 to 12 days, with the average actually being around 11 days. So typically 11 days after their contact with somebody with Ebola, then they start to actually exhibit symptoms. And fever is one of the top things, one of the top symptoms that they do exhibit. But in order to be classified as probably having Ebola by the WHO, this is what else you must have. You have to have contact first. Number one, contact first, okay? And it's 8 to 12 days after, and now you're exhibiting fever. You can have headache. You can have loss of appetite. You could have weakness or fatigue, aching muscles or joints, difficulty breathing or swallowing. I typically call that a sore throat. Vomiting, diarrhea, stomach pain, and a bizarre thing is hiccups. So if you have a combination of any of these three after contact and the fever, you're considered a positive Ebola identification case if you're in West Africa. Now, this is not necessarily going to be something that maybe is applicable to us, but these are some interesting symptoms because when you look at the first 5 of those, don't those sound like anything? Yeah. And that's because Ebola is a virus. Viruses cause very generalized symptoms, don't they? A lot of viral infections have these very generalized symptom complexes that they initially present, and later on, more of their favorite tissues or cells that they like to invade, you begin to actually show symptoms of that. If you have a more advanced case of Ebola, you will have bleeding. You will have bleeding from the eyes. You will have bleeding from the nose. You'll even have bleeding from their ears. You'll have hemorrhages under the conjunctiva. You'll have vomit with blood in it. You'll have diarrhea with blood in it. And then you can actually have rash with blood in it. But the bloody rash is not a hallmark, even though it's a hemorrhagic fever illness. It's actually not the hallmark of the Ebola that we're actually experiencing. Complications, severe bleeding, organ failure, shock, seizures, coma, and death. And so that's why so many people over in Africa are actually succumbing to it because they don't have anything that can actually help them when they actually have more severe symptoms. So as far as tests, what kind of tests are done for Ebola? They all involve blood. So the lab technician always has to observe proper lab protocol. And PCR is the one that is used most commonly. There was a test that you could get results for whether or not a person had any Ebola present in their blood 4 hours. They now have a new one that they've been able to actually get to 2-hour diagnosis. So they can get results within 2 hours, and they're going to be distributing that, to whoever wants it here in the United States. I have no idea how much any of these tests cost, but I think we should be sending them over to Africa. Send them now and get them tested if there's any suspicion so that you can start proper protocol and treatment for those individuals. You can cultivate the virus, but that's not something that's typically being done right now for confirmation. It's typically the first 2 blood tests up there. You can also draw blood and check the blood to see what kind of organ damage is being experienced by the individual. And liver damage is very prevalent because Ebola loves your liver. It loves your liver. And it goes, oh goody, I'm going to find you, I'm going to invade you, and I'm going to destroy you. And that's what it does. It loves your liver, and so liver damage is very common. Kidney damage. The other thing, though, why some people with bad liver damage recover is because the liver has remarkable regenerative capabilities. So that's why you can have terrible liver damage and still recover, because our liver is a remarkable organ. Kidney damage requiring dialysis, bleeding disorder, because our clotting elements come from the liver. So if you torch the liver, you're going to torch your ability to actually clot your blood effectively. And also, we'll talk about a little bit of the pathogenesis of Ebola as to why you actually clot first inappropriately and then bleed. Impaired immune response. This is what's really interesting about Ebola, because Ebola is going to actually get in past your surface barriers, and your surface barriers are your skin and your mucous membranes. In order to get into you, direct contact with mucous membranes, easier to invade. In skin, you actually have to have an open wound for it to actually get in via the skin. But once it gets in and the immune system sees it, this is what's really bad about Ebola. This is why people get so sick. The immune system goes, oh my God, I'm going to die. And they die without getting infected. Your lymphocytes, the key cells that are responsible for immunity, your lymphocytes see Ebola, says, I'd rather be dead than be infected by you. And they undergo apoptosis, or apoptosis if you want to spell it correctly. So they undergo cell death when they see Ebola. It's just like, what good are you? I mean, they just are like frightened out of their boots and they run away and die. And this is one of the reasons why we have such a poor response to this virus. Why this happens, I can't tell you. I'm just telling you what happens. As far as when somebody has treatment, treatment is supportive, but the first thing you do is isolate the patient, correct? Everybody's got that one figured out. Isolate. Isolate the patient, number 1. Fluids and electrolytes. They need large amount of fluids. And part of the reason that they need large amount of fluids is that also the endothelial cells, the cells that line our blood vessels, are attacked by the Ebola virus. So the cells that line our blood vessels are attacked by the Ebola virus, which means that they die. Okay, and if you lose the integrity of the lining of your blood vessels, you get things leaking out, correct? And so that's what Ebola does. Ebola causes us to become a sieve. Instead of a nice closed system, we become a sieve. And so people need fluids and electrolytes. There is a patient that underwent severe damage by Ebola and has recovered from Ebola and was in the ICU on a ventilator getting dialysis and all sorts of supportive care. And at one time in his treatment, he required 10 liters a day of fluids just to maintain his blood pressure. So when they say fluids and electrolytes, they are really talking about fluids and electrolytes. These people really need a lot of bolstering because they are becoming an intravascular sieve. Oxygen, of course, trying to help your system function properly. Blood pressure support, that's part of fluids and electrolytes. Treat complicating infections. Blood or plasma transfusion from a recovered patient. And that's what Dr. Brantley has done. Dr. Brantley has given his plasma to several people because he has antibodies in his plasma. He developed a normal immune response to this infection. And so now he has circulating antibodies in his plasma. And so they're trying to give people who have Ebola his plasma to see if his antibodies will help fight the infection for them while they mount an immune response and actually can fight the infection. So that's why that's been done. A couple of other things, ZMapp, TKM, Ebola, and Brincidofovir. I'm kind of butchering these as I pronounce them, but that's okay because you don't have to pronounce them very often. But ZMapp is an interesting one. ZMapp we're already out of. ZMapp's hard to make. ZMapp is a monoclonal antibody times 3. So remember I told you, in order to mount an immune response, we develop antibodies. Monoclonal means one one cell line, correct? Well, ZMapp is 3 different cell lines directed towards Ebola. And so ZMapp was actually given to Dr. Brantley, and we don't really know if it worked or not. But we're already out of it. So it's very hard to make, and it's very expensive. You know, things that are hard to make are always pretty darn expensive. But ZMapp was given to Dr. Brantley. Dr. Brantley did survive, but do we know if that is what actually contributed to his survival? And the answer is actually really no. TKM Ebola, there's a lot of issues with that one, but it's out there in the works, trying to pass various procedural aspects of it to see if it's actually something to actually use. But this antiviral, this brincidofovir, is an antiviral that actually works for cytomegalovirus and adenovirus infections, and it's been shown to actually kill Ebola in the lab, but it's never been actually utilized in living models. So those are things down the pike that people may be able to actually take, but still there's more studies actually needed to actually verify that these treatments actually really work. The other thing that is actually more important is actually the development of vaccines, don't you guys think? If we could get some vaccines and we could send them out to Africa, who would we vaccinate first? Healthcare workers. 1 out of 20 deaths from Ebola is in a healthcare worker. And they already don't have enough of them. Okay? And so you're going to give, if you get a vaccine that actually passes its stage 1 trials, you're going to be taking this vaccine over to Africa and you're going to be giving it to healthcare workers there. Because don't you want those healthcare workers taking care of those people so that they don't come over here trying to seek our care? Because if I was an American and I thought maybe I contracted Ebola, you know where I would be, right? I would be over here. Of course, I wouldn't be in Dallas. So, but I would be over here and I would be at Emory or something along that line getting my care for that. Because I would go to an area that I know does a really good job and actually recognizes things and knows how to actually medically support me if I actually hit the worst stages of infection. So you have to realize you do want these vaccines to go to Africa, and you want to start vaccinating people, the healthcare providers, and then you'll probably want to start vaccinating the public and populace over there so that they don't get it and keep spreading it, and so that it can come over here in waves. And so right now we have 2 vaccines in stage 1 clinical trials. And one of them actually developed, the first one that got into the clinical trial is from Canada. So Canada's been working on a vaccine a little bit better than we have. And now we actually have a couple of companies interested in the vaccine because there's a big public interest in the vaccine. And when there's a big public interest in something, that means there's money. And so, therefore, when there's more money to be made, there's more interest in these vaccines. And so your interest is actually a good thing. So method of infection and disease manifestations. So it has to get in. And it's easiest if it gets in via your mucous membranes because that's not a very thick cellular layer for it to actually invade. Or breaks in the skin or parenterally. But remember, it has to be contact. Contact with fluids. Any type of fluid from an infected person. Once inside, our barriers are considered our first line of defense. Now our second line of defense comes in. And those of you that have taken A&P from me recognize these first line of defense and second line of defense stories. Well, our second line of defense has many different layers or levels to it. But one of the big players in this are monocytes, macrophages, and dendritic cells. And these guys are all APCs, antigen-presenting cells. So monocytes are in the bloodstream, and when they enter the soft tissues, they become macrophages. They become phagocytes, and they go around yum, 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 eating up things that shouldn't be there. Okay? And macrophages, that's what their job is. I patrol the tissues, and I take out things that should not be here because it could be harmful to me. And they also are there to recognize harmful things and get them out of the system. And dendritic cells. Dendritic cells are our biggest APC, antigen-presenting cells. These are the guys that have to take the bad stuff to our immune system to tell the immune system we're under attack. Okay? So all of these monocytes, macrophages, and dendritic cells are all ingesting the virus. The virus doesn't even have to invade these guys. They're all ingesting the virus or being invaded by the virus. But once the virus is inside, it's in happy land. I'm happy, happy, happy. And the virus starts to take over the cell, and over its metabolic processes so it can actually replicate and then make more of itself and then explode the cell. The problem is it doesn't explode the cell right away. It makes sure this antigen-presenting cell goes to the areas where it needs to present the antigen to your immune system. It gets into your lymphatics and gets into your lymph nodes. And once into your lymph nodes, which are full of lymphocytes, then the cell goes boom, and all these viruses are all over the place. And your little lymphocytes are going, oh my God, I'm going to die. And then they run away. And so you get flight instead of fight. You go, what is wrong with you guys? I don't know. You know, is all I can tell you. But that's what apoptosis or apoptosis is. That is, all of our cells have this apoptosis inside them, programmed cell death, but they undergo immediate apoptosis. They immediately kill themselves. And so that's not good because lymphocytes are the big players in our immunity or our immune system. So then they're in here, they're replicating, they're having a party, and then they get into your bloodstream. And then from your bloodstream, then they can go to your liver, and they're in there where your blood vessels are. And so that's the other thing, too, is once they initiate this process where they're exploding cells, cells are actually releasing cytokines. And you know, sometimes you think, oh, why do I need to know about cytokines? Cytokines are very big players in inflammation. And so that's called fever, people. So when cytokines are released, we actually start to get manifestation of fever. But remember, this is now, these viruses are now in their happy land, in their lymph nodes, and they're replicating rapidly and now sending out infectious particles to the rest of your body. And the fever starts. And the inflammation starts trying to stop the spread, but instead, inflammation goes all awry. So then, now it's in the bloodstream, and it loves to land on endothelial cells, the blood vessels that line, the cells that line your blood vessels. And remember, that's what capillaries are, right? Capillaries are just one layer of cells, endothelial cells. And so now Ebola virus actually preferentially infects these guys, as well as hepatocytes, and causes these cells to rupture or lyse again. Because that's unfortunately what it does in us. And that's what it was doing to the monkeys, the chimpanzees in the Reston facility. It was infecting cells and causing the cells to rupture and die. And this is not good because one of the things that we actually have, I don't see it up here, one of the things that's actually our cells try to do, when a virus infects a cell, the cell recognizes it's being infected, okay, and it sends out interferon. You guys remember interferon? Interferon's the cell's way of saying, I've got a virus inside me, and I want you to know about it so that you can actually start to protect yourself so that the virus can't get inside you. So that's what actually interferon's all about. Interferon is a cell saying, I'm infected, I'm sending out a warning system to you so you can get yourself geared up so you can fight this infection and survive. Because the cell that's sending out the interferon is going to die, okay? But it's trying to help the rest of it. Well, Ebola doesn't allow our cells to do that. Ebola interferes with interferon release. So that's another reason why it can run so rampant, because our normal mechanisms of protecting ourselves from viruses is actually interferon release. And so Ebola stops our cells from sending out interferon to protect the adjacent cells nearby. And that's why it's so bad in the liver, it's so bad in your endothelium. The other thing is, remember, endothelium lines your blood vessels. And whenever you have a loss of integrity, isn't that thing called clotting supposed to actually happen? Coagulation? And so the first thing that actually happens before you start bleeding and oozing everywhere is that you actually start clotting everywhere. Because your blood vessels are coming apart and your coagulation's designed to stitch you back together, so to speak, you start having what they call DIC, disseminated intravascular coagulation. And so it's trying to keep you from leaking, and you're leaking, but then because the liver is being torched, all of your clotting factors, for the most part, come from your liver. So then you use up all your clotting factors, and then you're just like a bleeding sieve. So then when they check your bleeding parameters, your PT and PTT, protime and prothrombin, they find that it's way out of whack because A, they were all used up, and now, because now you no longer can patch up the holes, you are a true sieve. And so because you're a sieve, Now all of your serum and plasma is actually leaking out into the tissues, and you need 10 liters a day of fluid support in order to maintain a blood pressure. Are you guys starting to understand why, as an A&P instructor, I just think this is so fascinating? And you go, I thought I'd never have to remember that stuff ever again. Oh. So, interferon release is blocked. If unchecked, it infects the adrenal cortex. And you know, the adrenal cortex is very important for your ability to actually handle infections and sepsis and all those types of things. So it's being taken out of the picture. Fibroblasts and epithelials, I mean, that's if we let things continue to go unchecked and there's no actual real immune response. And that's what they've actually shown. Survivors develop a humoral response. And those of my students that are taking the exam on Thursday need to know humoral response is what type of cell, Michael?
That would be B cell.
That's right. All right. That's pretty good. Yes. Humoral is antibodies. Antibodies are proteins or immunoglobulins. And our B cells are the cells of the lymphocyte that is responsible for making this. And so remember, I told you, the lymphocytes are going, oh my God, I'm going to die, you know, so I'll just kill myself instead, you know. And so that's why we have such a delayed response, because this initial infection causes our big players in this process to actually go down. And that's why the white blood cell count, our protectors of us, numbers are down in our early stages of infection with this. So what they have shown, though, is that your immune system will actually recover. You know, it will go out of its shock, self-induced shock, and recover. And the survivors do develop a humoral response. They develop actual antibodies, which help them fight the infection, get rid of the infection. Those that do not survive have absolutely no evidence of antibody development. I mean, that's why they're just like their immune system. I don't know what you are. Take me out. I give up. And that's what happens for people that actually have died from it, especially those that have died very quickly. So let's talk about what happened to our first case of Ebola that was diagnosed here on the U.S. soil. First off, what you may not have known, on August 8th of this year, the World Health Organization declared the Ebola epidemic in West Africa an epidemic out of control and a public health emergency of international concern. This is what they have to do to get money. You know, they have to declare, you know, it's like on Lost in Space, the robot going, warning, 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 you know, danger, you know, danger, Will Robin, you know, danger, U.S., you know, and they need help, is what they're saying. We are having an extremely difficult time containing this, because this Ebola outbreak has killed more people than all of the Ebola outbreaks added together already. So that is why this one is so bad. It's killed more than all of the Ebola outbreaks that we have on record. And it's mainly due to this very densely populated area with very poor resources. And so they're saying, we need help, we need people, we need supplies, we need medical facilities. We don't even have facilities for these people. And that's actually part of the problem of what actually happened here. I bet you probably did not know that Liberia and Nigeria were already screening people. After this proclamation came out with the WHO, they were already screening people that were arriving or departing from their airports and seaports. They were giving them a medical and contact questionnaire, and they were actually checking their temperatures. This was happening way before our first case actually happened here. But the other thing that happened, too, is that Guinea, because it was having such a problem and afraid of spread, it did close its borders with Liberia and Sierra Leone. And I'm going, good luck with that. We try to close our borders, and not much comes out of that, you know. So, you know, you can see some efforts are good and some efforts aren't going to be so good. You have to be realistic. But they're trying to do what they can. And, you know, if you're afraid that somebody's going to give you Ebola and you're a guard with a gun, you know, I guess you're going to go ahead and shoot them if they try and come across your border. I don't know. I have no idea how it's actually being managed there. But one of the things that's important, because the WHO declared this an emergency and an epidemic out of control, did you guys know that the CDC actually sent out a memo saying they wanted, on the intake history of all people being seen in emergency rooms and various places, part of the question to be asked is, have you recently traveled from West Africa or any of these countries in Africa, Liberia, Sierra Leone, and Guinea. And that was actually, they said, put this on your intake screening questionnaire for people coming into your facilities. And indeed, it was. So our healthcare places actually did put this question on their intake forms in the emergency rooms. But Thomas Duncan, he lived in Liberia, and all he was doing is he was trying to help a neighbor. And he helped transport a pregnant woman back to her home after she was turned away from a hospital due to no room, even though she had Ebola. That's how bad it is. That's how bad it was before he even got here. So here's somebody with Ebola. She's pregnant, and he's trying to help her at least to get back home to where she can, live or die in her own home. Okay. But on the 19th, and I can't tell you exactly when this happened, but we can actually do a little math when you consider 8 to 12 days as the window. But on the 19th of September, he wanted to fly home. And so, or not home, to see some family members here. And so he got on a plane on the 19th in Liberia. He went to Brussels first, and then he went to Dulles. How do you pronounce that airport? Dulles? Okay, I never go there, so I don't know. There's not too much that attracts me on the East Coast, so. And then he landed at the Dallas airport on the 20th. It took him a whole day, to get there, okay? And he was not contagious. He wasn't infectious. He wasn't sick. Everybody on those flights were just fine. But on the 24th, he developed symptoms. And on the 25th, he went to the hospital. And he told the nurse who did his intake history, because it was on the form, she asked him, have you recently traveled or returned from, West Africa or blah, blah, blah? And he said yes. And she marked it. This is like a football game to me. This is Team Ebola versus Team U.S. healthcare system. And I tell you what, Team Ebola won this one. This was the worst game of fumble after fumble after fumble after fumble. It was one of those football games you just want to cry about. It's just like, oh my God, I really like that team too. I'm for our team, but our team is not being realistic in its education and its preparedness and its willingness to actually think outside of the box. And healthcare actually has a tendency to do that at times. So he told the nurse, and she marked it in the records, and she didn't do this. She didn't say, oh, we got this guy from West Africa, and he's got a bad fever of 103. I'm going, Ebola, Ebola, Ebola. I mean, it's just like, the robot would have been just spinning around at this stage, okay? And so then he was seen by the doctor. And I don't know what he told the doctor, and I doubt that the doctor really wants to tell us what was said. Because, when you have egg on your face, you just want to forget about it, don't you, for the most part? But what happened was the doctor saw him, saw the 103 temperature, did not see that he had traveled recently from West Africa, and didn't think anything about it because he didn't see it. One of the things that I heard early on, and I don't know if it's true, he says, well, I don't read all that stuff. I go, that doesn't help. That doesn't help. Why do people fill out those forms then if you're not going to read them? But the other thing, remember, if this is an electronic health record system, shouldn't that electronic health record system been saying, flashing, to the doctor? So obviously when they put it on their forms, they didn't do a very good job, did they? And they also didn't do a very good job of transmitting to the nurse. You just, if somebody says something like this, you make sure that information has been transmitted to the next person in the line of command. Because one of the things that I know about patients is a lot of times patients think when they tell you something, that you're telling somebody else something. And so they don't say it anymore. They say, well, the nurse, I told the nurse told the doctor, and the doctor doesn't seem to be concerned. I guess I'm okay. Can you imagine the sense of relief that that person probably felt? Oh, I don't have Ebola, That's probably what that person probably felt. Peter has a totally different attitude about this. I go, you just haven't been around patients enough. You just don't understand. He goes, he should have been telling every single person that he talked to that he was from West Africa. And I go, you know, I don't know why he didn't, but I know how patients are. They say, if I tell somebody, that information is going to be transmitted if it's important, right? And so you have to realize, when you see something and you think it's important, you just don't mark it in the chart. You also do a little bit of vocalization about it to the next person in line, because that's actually that's important. And that way you did your job. Because if the next person, you marked it and you told them and they do nothing about it, you did your best to try and make sure it was actually attended to. That did not happen here. So this was a fumble, 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 fumble. You know, it fumbled all the way down. Because what just absolutely galls me, in addition to the doctor not reading the chart, he diagnosed the man with a viral infection and sent him home with antibiotics. Do you know how much I just cringed when I saw that? I go, oh, don't do this to me. Okay, so he sent him home with antibiotics, which were obviously not going to do him any good, especially when you said you have a viral infection. Oh, is that a bacterial viral infection or a viral bacterial infection? Which one is it that you need antibiotics for? So then he goes home, and you can imagine, you know, that's what I would imagine. I would imagine relief. Okay, I just have some bug. Bugs are typically viruses too, by the way. I just have some bug, and I can take these antibiotics, and it will get me all better. Because I'm in the U.S. healthcare system now. I'm not in the Liberian healthcare system. I'm in the U.S. healthcare system. Well, that didn't work too well for him. The other thing, too, I want to tell you is, what do you take when you guys get a fever? Tylenol. Now, who's really sick right now inside the body? The liver. What does Tylenol do to the liver? Oh, man. Can't you just see? He got sicker and sicker because of trying to actually make himself probably feel better. So he actually insulted the system that was already trying to do whatever it was trying to do, was trying to actually survive. But then he went home, and he became so ill that an ambulance had to transport him to the hospital. And I am so relieved that those first responders never got ill, because those were the people that were really, really at high risk, weren't they? So they did something right. Those first responders, that ambulance crew, did something right. Okay, and he got to the hospital, and this is another thing. He was placed in isolation, and they used standard PPE. And I'm just going, what are you telling me? Is that what I think it is? Oh, my God. You know? And that's because on the 28th, they weren't sure he had Ebola. I go, contact, Africa, high fever, sicker than a dog, you know, and I'm sure his blood tests actually confirmed all of these things that I told you. But it wasn't until they got a blood test back, and this was before they got even faster with their PCR. It took at least a 24-hour time period for this blood test to come back. Once they got the blood test back for Ebola, they totally changed the program. And I go, why now? You know, why is it that you now are starting to get it figured out, that, you know, it's right in your face, but you need it on paper to spell it out for you? You know, and that's why we do need to pay a little attention to what the WHO is telling us. When the WHO is telling you something, do actually check it out a little bit. It's good. And we also found, because we were so slow, we were just like the countries, those 3 West African countries, we were so slow to recognize it and to respond to it appropriately. We had the same infection rate that they do over in West Africa. For that one patient, because of our poor PPE protocols, 2 got infected. And so let's talk about what was happening. All you have to do, this is the other part that I don't understand. Here is somebody in a hospital suspected of having Ebola. And it's even in the news. You know, Dallas, looks like you screwed up. It's even in the news. And this is what they were wearing in West Africa before we had any Ebola outbreaks. This is what they wear for PPE when they're out in the field. Do you see any skin exposed? You know, there are some things that they're reusing, because remember, they don't have a lot of resources. So their boots, yeah, they're using their boots. They're, I'm sure, reusing their goggles. And if they, a lot of them actually are wearing what I call your your latex gloves that you have for washing your dishes. They have to use those things because they don't have any money. but they can actually use on this virus, and even the hardier viruses, you can use a 1 part bleach to 10 parts water solution, and you can kill the virus. Now, with Ebola, because it's got a capsule, all you actually have to do is, if you know, because who really wants to wash their hands with Clorox? You would not wash your hands with Clorox, right? Please do not. And the reason I say that is people are actually trying to drink Clorox to prevent themselves from getting Ebola. They're washing themselves with Clorox, you know, so they're giving themselves, you know, bleach poisoning. But that's what happens when you're scared and uninformed, correct? People do some of the dumbest things when they're scared and uninformed. But this was the PPE out in the field, standard PPE in West Africa. Here's us. Guess which one's the before picture? Here's the before on the 28th, and here's the after on the 30th. Which one looks more like what they were doing in West Africa? You know, and so the standard PPE is not good enough for something that needs to get at you. Remember, it needs to get at you. So you should make sure that it can't get at you. And especially with Duncan, when he got here, wasn't he sicker than a dog? I mean, he had vomiting and diarrhea, and he was I mean, things were flying all over the air. And so these nurses were taking care of him initially with this style of PPE. This was their standard PPE. After confirmatory tests came back that he had Ebola, then they changed their PPE to where they looked actually like people that have no way that anything flying through the air can actually get to you. And the other thing, too, he was so sick that they were doing invasive procedures. So he was intubated, he was on dialysis, I'm sure they had central lines in him and all that kind of stuff. So, you know, whenever you have an invasive procedure, you actually increase things going into the air whenever you are doing these things. And so you need to be more protected. So the thing that gets me is that, you know, they didn't even have this on. They weren't even wearing hairnets. CDC issued these guidelines, by the way. This was okay to wear when Ebola first got here. And that's the other aspect of the whole program. It wasn't just the nurse. It wasn't just the doctor. It wasn't just the hospital. It was also the CDC. They were unwilling to look at that we need to be as vigilant here as we are in West Africa. So they weren't even wearing anything over their hair. They weren't even wearing anything over their feet, for crying out loud. Okay? And so, you know, I don't know which mask you prefer. If you were to have a mask, which one would you prefer? One that's all by itself? Yeah. This is an N95 respirator, they call it. It's a very fancy face mask that is actually designed to really minimize your exposure to anything that's actually floating around in the air. It does a much better job than any of these things do. And this is actually part of the PPE protocol that they're actually advocating now. So, but yeah, so they're wearing this. They're not even wearing a hairnet. By the way, you're not supposed to wear earrings, too, when you treat Ebola patients. You're not supposed to wear any jewelry, correct? When you treat an Ebola patient, right? You don't want your hands going to those areas, messing with them. You don't want touching yourself. You know, that's the other thing. You know, the average person touches their face anywhere from 3 to 16 times in an hour. No duh how it got spread. Seriously. So anyway, as I put this stuff on, and I look really goofy, I think of how when they first said that the nurse breached protocol, and I'm just going, she did not breach protocol, you buffoons. I really did think those things. Some of you guys may have actually heard me say it too. You know, she was wearing this, and not even a hairnet, and making sure her ears were, oh, it's hard to do this with your ears covered, evidently. I thought it sounds funny on the microphone right now. She was doing this. Isn't this standard? Mm-hmm. And I wonder why this is standard. I think it's because it's low budget, personally. Yeah. So, yeah, standard. Wasn't even wearing booties, for crying out loud. Okay. And most of you already know what it is that I'm doing here. But the thing about it is even if this is all that the ambulance people were wearing, even if This is it. And they weren't. They were wearing the regular shoes and stuff along that line. One of the things that's real important, it's not just what you're wearing, it's how you take it off. So this could have, actually in real life, this could have actually been sufficient. Could have. But I tell you, I don't believe so in the two young ladies that were victim of this. So I've got this on. Typically just one pair of gloves, right? Now how am I going to get this off without getting any part of me infected? Or, say I've got secretions on my hands because I was doing a procedure or cleaning up vomit, or diarrhea or something like that. How am I going to get my garb off without touching me? You're going to have to do the gloves always first. And you have to do the gloves in a fashion to where, obviously you don't get the gown infecting your hands. That's hard to do, isn't it, with only one pair of gloves? You have to get the gloves off first. Well, even now I've already contaminated myself, correct? Okay, so that's not going to work, okay? And so single glove doesn't work. The other thing that we all do when we get out of this, you can't do that. You have to untie it, and you have to get out of this to where, in theory, none of the contaminated surfaces touch you. Well, already you can see that's no way. There's no way I could get out of this. So I didn't get out of this with the gloves. I can't get out of this with the gowns. And then, what else am I going to do now? Take this off. Well, is this not a contaminated surface, potentially contaminated surface? So even taking this off, I'm contaminating myself again. And then if I take my hairnet off, aren't I contaminating myself again? And then I take my booties off. Can you see how easy it was to get contaminated with this? And so it wasn't that they weren't following proper PPE protocol. Nobody had told them how to take it off without getting contaminated, because that's actually what's more important. The most important thing is not just putting this on, but taking it off. And so now, this is what they're doing. Donning and doffing in PPE. Let me see if I did anything on donning on the other. Yeah, donning. Okay, this is what they want you to do for PPE. Surgical boot covers that you cannot penetrate. Tyvek. You guys know what Tyvek is? It's pretty good. So you have to get them on. Always a lot of fun, isn't it? This is why they say it takes time, right? Donning proper PPE takes time. So, my boots. The operating room has all of this stuff. You guys do know that. So it's not like the hospitals don't have most of this equipment. They have this stuff. Then you have to get your gown on. ALK is a pharmaceutical manufacturing lab here in our area that actually donated this equipment so I could put it on. But you have to, and with ALK, the boot covers would actually go on the outside. For us, they say boot covers on first because typically you don't wear a suit like this. You wear a gown, correct? So boot covers should be on the outside of this guy. You guys recognize that, correct? Okay. So then with ALK, they have this. And if you're wearing hazmat suits, because this is more like a hazmat suit, correct? Okay, if you're wearing where'd my arm go? If you're wearing a hazmat-like suit, they actually have little areas in here for your thumbs so that the suit doesn't get pulled down. Okay. So then you have to, of course, get into your full garb here. And this is also not going to be penetrated by any fluids. That yellow thing, does it get penetrated by fluids? You bet it does. So you're wearing garb that does not get penetrated by any fluids on your feet as well as on your body. The other thing, too, is you have to triple glove. Triple glove. I'm only going to put one on. You have to triple glove, and the second layer is supposed to be extra long nitrile gloves. Because you want to have at least 3 layers before you actually start to remove your equipment, because you can actually see how quickly you're going to actually remove gloves as you remove a layer. And then those gloves get contaminated, and then you have to remove those gloves because you have another layer to remove. So triple gloving, wearing an N95 respirator. Have you guys tried putting these guys on? It's a challenge, isn't it? Let me see how I do. Can I keep my earbud in? Probably not. So you have to put one of these on, and you have to make sure the seal is good. These actually have excellent seals on them. And then you have to have, obviously, a hat. Should the hat be on before this? The hat should actually probably be on before this, because it's going to be hard to actually get this all off. But you have to have a hat and a visor. And if you're really into making sure you don't come into any contact, then you wear a PAPR. Do you guys know what a PAPR is? It's a powered air purifier respirator. And the PAPR goes on the outside because it's hooked to a battery pack that actually is hooked up to a vent fan system that blows air out, and so the air is actually blowing always out away from you. I'll put this on just for giggles. Thanks, Kelsey. But you're hooked up, and you're in this, and you're actually able to do things except get claustrophobic right now. Okay. You get hot in that darn thing very fast. But donning is an art. Putting it on, putting all of this equipment on is an art, and you need some help. That's what the buddy system is for. The buddy system is to make sure you put it on right, in the right sequence, and that there's no contamination or open spaces to you. But what's more important than donning or getting it on is doffing. And they actually call these people doffers. So there is a nurse in a separate area that is there to help you put your PPE on when you treat an Ebola patient and help you take your PPE off. And you actually have to stand in certain areas of the doffing room. You're going from a more contaminated region, and as you remove stuff, you're going into a less contaminated region, and then when you're finally done, you're going into a area where you are actually considered free. They even clean your shoes with a bleach solution. And so you have to use a doffer to get this stuff off. You come out of the room. Before you come out of the room, you actually are cleaning that third outer layer of gloves with 1 part bleach to 10 parts water. Then you're touching the door. Then you're coming out. And then you're getting rid of those gloves. Okay? So remove first layer prior to leaving patient care room, but you actually clean those before you removed them. Then you remove them. Then you clean those, the second layer, before you actually leave the room. And then you're in a separate room and you remove the gloves and you get out of your gown and you ball it up to make sure you touch nothing. And you still have another layer of gloves on, correct? Because you have that innermost layer. And then you get your boot covers off, and then you get your gloves removed, your hands clean, new gloves applied before removing the face shield and hood. Do you see every step along the way is important, that what you touch, whatever you're touching, you will not transmit it to something underneath your gloves. And that's one of the problems that actually happened with the poor young ladies, because they were absolutely the proper people to get Ebola. Young girls with long hair. After you take all this stuff off, What do girls like to do? Oh, they do primping, right? You know, say, I think if I'm going to treat this Ebola patient, I'm going to go in and get a butch haircut, and I'm going to leave all my jewelry at home. Okay? You know, no makeup, no fancy hair stuff, no jewelry. You know, when you have somebody that's highly contagious, you don't want to touch yourself with your hands. Okay? And so even though you do everything right, you know what you should be doing all the time, right? You should be washing those hands, washing those hands, washing those hands. You can't wash them enough as far as I'm concerned, because that is actually the best method to prevent disease transmission. You guys all know that, is actually your hands. And that's one of the reasons why I'm fairly sure Ebola was transmitted to all those primates at that primate lab, because of how people were handling them. They called those people the handlers. And I'm going, yeah, I know how they were handling them. Okay. So we have 4 biocontainment units in the United States that are actually designed to be treatment centers for bioterrorism or disease level 4, which is what Ebola is. Ebola is a level 4 disease. What I thought was most interesting, because I always kept hearing about 4, 4, 4, and I didn't realize that we had one 3 hours away. So St. Pat's Hospital in Missoula, Montana is a biocontainment unit here in the U.S. So after they had all those fumbles and failures with all those young ladies, they actually finally sent them to a facility that was actually designed to treat them and take care of them and had all the resources. And that's reasonable. I actually don't understand why New York doesn't want to actually send that doctor to one of these biocontainment units. I think they want to prove they can do it. And I'm just going, just prove that you can recognize, isolate, and get this person to an area that actually can take care of them. Because there's been at least 8 people that have already been treated at these biocontainment units and actually survived and are now declared Ebola-free and have been released from them. So they're doing a reasonable job, but the amount of waste generated by taking care of one Ebola patient is huge. It is huge. You have to actually have all kinds of autoclaving. You have to have incineration. As a matter of fact, all of the waste that were generated from treating Duncan, they are actually now going to send them to my old alma mater, University of Texas Medical Branch of Galveston, for the incineration, because they are actually an approved facility for the waste management of Ebola-infected patients. And so there's so much involved in taking care of these people. What you want to be able to do is you want to be able to recognize them, isolate them, stabilize them, and get them out to the places that actually can care for them. And so I'm totally perplexed as to why New York's doing what it's doing. So what can you do to make yourself safer? And this is the take-home, too, for you to talk to other people. And I call it prepare. So the P is don't panic, prepare. R, read reliable resources. Well, what are reliable resources? These are the resources I actually utilized in my talk. I actually utilized the WHO, I utilized the CDC, I utilized WebMD, Medscape, Medicine.net, and the National Library of Medicine Global Health Events. And I've done a lot of reading, and I've been doing a lot of synthesizing. And so I've taken a large amount of information that's been very complicated and tried to actually give it to you in a format that I hope is somewhat digestible. Have I been doing okay so far? Okay. This did not happen overnight. This actually took weeks of actually reading through this stuff and actually paying attention to things when they were actually occurring. The other thing, evaluate critically what you hear. People, when they're afraid, say really strange things. And so you have to help to, when you hear things, you have to kind of allay their fears and get them to understand a little bit more that everything's going to be okay, because it is going to be okay here. And news media is designed to do what? Scare and sell. You know, it's designed to sell. And, you know, ho-hum boring stuff like these sources that I've gone to, it's not very news media-like, you know. So it's sifting and reading through, and when are they going to get to something that means something to me kind of stuff that I can actually synthesize into a format that you can understand. Practice good hygiene. Oh my gosh. Remember, Ebola is a virus and it's not hardy. So drying will kill it. Ultraviolet light will kill it. Alcohol-based hand sanitizers work on viruses with capsules. So yes, alcohol-based hand sanitizers are very effective. to help with just the general cleaning of the hands. But the best thing you guys all know is washing your hands with good old soap and water for 20 to 30 seconds. And does that soap have to be an antibacterial soap? Because Ebola is not a bacteria. And most of our infections that are transmitted are viral. So good old plain, that antibacterial soap you guys know is a scam, right? Yeah, it's just propaganda trying to get you to buy them and so they can charge you more. Just soap and water, people. That's all you need. Okay. Cough or sneeze into your shirt, arm, elbow area, correct? Everybody knows that, right? It's this for coughing and sneezing. What I like for right now, that's a fashion statement right now, is this is scarf time for women, yes? There's these really fluffy scarves that I like, and whenever I cough and sneeze, I put it right up to my face and catch it. It's just like a little mask that catches it all. So really encouraging people to do that. And then, this is actually the hardest part. You guys should actually count how many times be aware of how many times you touch your face. Keep your hands away from your face. It's much harder than you realize. I would like to ask that you guys consider adding the WHO to your levels of philanthropy and maybe some of your reading lists, because they are the ones that actually started off with all of the information about how to treat Ebola, how to diagnose Ebola, how to do it all, and the CDC misread all that information to our public. So do you understand how one person's misunderstood the information, somebody at the CDC misunderstood the information that was being transmitted and put it into a format that led others to believe this was a reasonable thing? All of their stuff came from the WHO, and somebody in the translation messed it up. And so the WHO is a much more reliable resource than the CDC. Though I'm not telling you not to believe the CDC, they're trying to catch up, correct? Not into your hand, Gerard, into your shirt or your coat, okay? And then realistic risk assessment. What is our risk, people? It's almost zero, isn't it? We can't say zero because we can't guarantee anything in life. But our risk is really essentially zero. It's that low because it's contact. It's not airborne. It is not airborne. And so remember, Ebola virus has a capsule. Did you guys know influenza virus is also a capsulated virus? So it's not hardy, but it's spread via air, okay? So realistically, when people are getting sick with high fevers, they're actually developing influenza. So influenza is transmitted via airborne. Ebola is transmitted via direct contact with an infected person and their secretions, okay? Flu season is here. I'm a big advocate of getting a flu shot. The students that gave me my flu shot, first question to them, so what is this? Is it trivalent or quadrivalent? Don't be surprised if you get people asking questions like that. Because with the trivalent shot, there's only 2 influenza A, 1 influenza B in it. And the quadrivalent, there's 2 A's and 2 B's in it. And so that gives you actually better protection. But we are giving out the trivalent here. Alcohol-based hand sanitizer is okay to use, especially on viruses with capsules. So in other words, it's good for influenza. Washing hands with soap and water, I cannot drill that into you more than enough. Isn't it horrible? Our bathroom upstairs, I go up there, I try to wash my hands. I get a shower. Yeah? And I've got soap in my hands, and I put them under that darn thing, and I actually counted it today. 1, 2, 3, 4, 5, 6 off. 1, 2, 3, 4, 5, 6 off. And I just wish I could get the janitor to actually turn it to where the flow wasn't so forceful and that it was on for at least 10 seconds. Because then you could say, 10 seconds have passed. Okay, I'll do another 10 seconds. You can give yourself 20, or you can give yourself 30, however you wash your hands. I just wish that I had that much power. I don't. So, cough or sneeze into your shirt, arm, elbow area. And then this is good to have around the house. 1 part bleach to 10 parts water. It's a great disinfectant. It works beautifully. And the N95 respirator, which was this one that I have here, you guys know I got this at Home Depot, right? You can go to Home Depot or Lowe's and you can get these. So they're not hard to actually find. And I actually think that this is what I should have worn when I was cleaning out my garage and ran across mouse droppings, yes? Oh, yeah. So this isn't bad to actually have on hand, okay? The nitrile gloves, you can get these anywhere too, right? These aren't bad to have on hand around your house. And then alcohol-based hand sanitizer. whenever you think appropriate. Because one of the reasons that, people are afraid to travel, aren't they? They're afraid to go to airports, correct? But realistically, what's their risk even at the 5 airports where people are flying in? Their risk is still close to 0. But if you have any questions, wouldn't it be nice to have in your purse or your bag a little N95 respirator, alcohol-based hand sanitizer, nitrile gloves? What's it going to hurt if you show that you're a little paranoid? It doesn't matter, does it really? It doesn't matter. So if you want to wear something like that when you're out in those areas, definitely do. Because right now at the U.S., you know that they're actually doing surveillance on people returning from these countries, from West Africa, from Liberia, Sierra Leone, and Guinea. They're actually checking them. They have to answer, in our country, a health screening questionnaire. In other words, do you have any of these symptoms? Okay. And have you had any contact with anybody that may have been infected with Ebola? And then they take their temperature. Now, how are they taking their temperature, people? Infrared. So that's a little gun, right? A little gun. And where are they taking their temperature? Forehead. I knew it was going to be the forehead. I knew it was going to be the forehead. And I know that that's not as accurate as the neck. The neck is a much more accurate area in which to actually record people's temperatures. It really is. But we always do what's easy, isn't that what we do? Is that always right? No. And so they're taking temperatures on the head because also I call that a no-brainer. Telling somebody, you need to uncover your neck so I can take your temperature. And so what are you doing? You're messing with my human rights. And I can just go, get your neck shirt down and let me take your temperature. It's like the stewardess on the airplane. She says, let me check your shoes for bombs. You go, okay, here are my shoes, that type of thing. You just don't impede people who are trying to do their job as reasonably as they can. But JFK, the Newark Liberty Airport, the Dulles Airport, Hartsfield-Jackson, Chicago O'Hare, this is where they're actually trying to funnel all the people coming over from West Africa to these airports so that they actually have to go in here. And then they have to, we have people coming from this area that have been treating people with Ebola, correct? Because that's what Doctors Without Borders are. That's what missionary work is. They need a lot of humanitarian help. And so that one doctor that landed in New York, he had been, from, which one was it? I thought it was Sierra Leone. Was it Ghana? Okay. He had been, not from Liberia, but one of the others, Guyana, and he wasn't symptomatic. And so he was taking his temperature twice a day. He's being a good guy, taking his temperature twice a day, and, laying low. And then he started to think, well, I'm okay, right? Isn't that what most people do? I'm doing fine, I'm okay. And so he started to get out and wander around a little bit. Well, he got out and wandered around a little bit, and then the next day he became ill. Okay, when he was out wandering around a little bit, his chance of actually causing anybody to become infected were pretty much still also close to 0. But because people are afraid, we have our systems actually geared for our fear, not for reality. They overreact because if I had somebody say, well, when they transferred that nurse to the Ebola care facility from the Dallas hospital, there was somebody there in the transfer that had no PPE on. And I go, but she was in a hazmat suit, for crying out loud. I mean, she was contained, So, and then also, we have had people transferred over to the United States with Ebola for treatment because they are our people, and they are missionaries at heart. They're wonderful, kind people at heart. They unfortunately get Ebola because, remember, 1 out of 20 deaths is in a healthcare worker, and they transfer them over in these, in these cocoons. They are secured. They are not contagious. And so they're coming over on airplanes, and they're putting plastics over the seats and things like that, but they are truly in almost like a hyperbaric type of chamber for their transfer. And so, when they're highly contagious, you can actually transport these people in various devices. Like you can put them in a hazmat suit, which means that nothing is getting to them, so nothing is getting out from them. And so when I was listening to that, I go, well, yeah, she was contained. Well, what does that mean? She was in her cocoon, and none of her stuff was going to get out. And the suit that she had on would not allow any of the air to actually come out. So you have to realize that you can transport these people safely, but it's all in the amount of containment, all in the amount of being prepared, correct? And so one of the things that you guys didn't realize is that Liberia was already screening before Duncan came over. And, you know, Peter said he lied on his question. I said he may not have actually realized that he had touched anything that had her Ebola secretions in it, you know. And, you know, denial goes a long ways, doesn't it, people? You know, when you want to get someplace, you know, people lie, too, don't they? They out and out lie because they don't realize the danger of their lies, do they? You know, so I'm not saying he lied. I'm not saying he was trying to deceive. But I'm saying that he got here and we were like they were over in West Africa. Our first one landed on our doorstep and it was all denial on our part, too, wasn't it? You know, this isn't bad, this isn't here, and so therefore we're not going to react until you say, Ebola on a piece of paper, you know, from the lab, you know. So our chances here in Coeur d'Alene, Idaho, and Post Falls, and Hayden, and all our surrounding area is actually 0. We're more likely to actually have hantavirus, correct, than Ebola virus, and then also the flu. And so when people are asking, well, what should I do, what should I do, reassure them that this is not airborne, first off. If they're going to get sick, they're most likely going to get sick with the flu or any of the colds that are actually running around right now. And then say, well, you know, those hand sanitizers work. Those N95 respirators, you can buy them at Home Depot. You know, nitrile gloves if you feel a little uncomfortable. You know, those are things that are okay to carry with you. But, you know, they're not necessary. There's one person that I'm actually thinking is going to get Ebola for sure, though, over in New York. Do you guys have any idea? I think it's his fiancée. I think his fiancée is going to get Ebola. So there's still going to be more Ebola cases. They're going to actually get through, and they're going to, you know, they're going to get through the screening. They're going to be asymptomatic. They're not going to know they were in contact with other people, or they're going to lie about it. You know, so we're going to hear about more Ebola cases. You know, that's just reality. But understanding how it's transmitted, understanding how easy you can actually kill it, understanding the volume of the contamination is very, very important. You know, those are things to actually tell people. You know, if it's spit on the sidewalk, for crying out loud, you know, I'm not worried about it. You know, you can spray it down with a little bit of Clorox bleach solution, correct, if you're worried about it. So those types of things, you need to actually, that's part of your job. Part of your job is realistic risk assessment and then reassuring people of their risks, and also giving them just a few comforting things to do whenever they're not comfortable with what you're saying, correct? Because people are often, you try to counsel them, you try to give them your best advice, and all they hear is wah, 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 wah. I'm going to get Ebola. And you go, oh my gosh, you didn't hear a single word I just said, and the answer is, yeah, they didn't hear a single word you just said. And so you just do your best. Correct, guys? Do I have any other questions? I know it's been a little bit of a talk, but I knew it was going to be about an hour and a half. Any questions that I can answer for you? Yes?
I've been following the way the different states in the East have been reacting to
Oh, yeah.
Ebola cases. I was wondering if you've heard anything about Canada or Western Europe.
I haven't been paying much attention about what they're doing with Ebola in Canada or Western Europe, because, you know, I've not heard of any cases in Canada. I've heard, you know, of the cases in Western Europe where they actually had that priest die from Ebola, and the caregiver that got infected from him, but she's actually recovered and is now Ebola-free. So I haven't heard about that, but you guys know that they're trying to do quarantine on these people, yes? And, you know, how is that going to help the WHO get more people over there to volunteer? There's always these things. Ebola is not easy to spread if you are paying attention, correct? If you are paying attention, Ebola is not easy to spread, okay? And it only spreads if you have an Ebola person next to you, right? So Ebola is not easy to spread, and there's somebody that has it next to you. Well then, you know, if you're a meter away from that person, you still have almost zero chance of getting it. So we are going to get more cases, and we also, do you guys know about the military that's being deployed over to those areas to help them? You know, they're not there for martial law. What our military is actually doing, these are like what we used to call the Seabees. These are people that are going over there trying to make care facilities in Liberia. 17 care facilities they're trying to actually create so that these people with Ebola can be treated in a reasonable facility. And then, of course, you still need staff, right? And you need supplies and stuff along that line. And then you need these people not to bathe their dead, right? You have to tell them. And, you know, and they just, you know how it is when people don't believe you. You know, what does it take to get them to finally believe you? But you've got to get these people actually have to have help in order to contain it so that it doesn't continue to come over here. Because one of the things I know about Sierra Leone, they had been doing the screening before we ever started screening, and they detained 77 people with fever, okay? None of them had Ebola. They all had malaria. And so malaria is going to be, these people are going to be coming over, and they are going to have people that are going to exhibit fever symptoms, and they are not going to have Ebola, because malaria is much more endogenous, endemic in those areas. And so we're going to see people with fevers, but they're going to be without Ebola. And that's nice that we have a PCR test that's just got a 2-hour turnaround for it. So I may not have answered your question. Thanks. Yes?
So the folks that do recover from it, are they immune to it then?
They do have antibodies. You can only recover if you develop antibodies, because if you don't develop antibodies, you die. It's like your system has been invaded by some monster it's never ever seen. So they do have antibodies, but they have a huge road to recovery. They actually can have hearing loss. They can actually lose their vision. They have hepatitis. They can have hair loss. They have all kinds of complications that they actually have to deal with in their recovery phase. So when you survive it, it's a long convalescence for these people. Yes, Lisa. Oh, it's not Lisa, but
They're only contagious if they are exhibiting symptoms.
yeah.
What about before that, like if they were to cough on their hand, even though they're not like coming out of every orifice yet, but if they were to cough on their hand before the symptoms, are they contagious then?
The viral load is not going to be very high. And remember, it has to, if they cough on their hands and they touch a doorknob, you're going to touch a doorknob with your hand. And as long as the viral load is low and you don't have any breaks on your hand, it's really not going to be an issue. It's the nose pickers, it's those, people that have it more of an issue. And so, like a day before, I can assure you, viral load was not high enough yet to be of concern with disease transmission. But I can't guarantee, because as I said, it's always a little bit different with everybody, because one of the very early symptoms for all of these people have been fatigue. But, you guys are tired. Do you have Ebola? No, you don't. You know that. Yes.
How long do they need to be infected, or do they need to be symptomatic in order for that PCR test to be considered reliable?
Well, in the beginning, they said that they needed to be symptomatic. Sometimes they do not detect enough virus. This also helps with your question. When they start to develop the fever, sometimes that PCR test comes back negative. And so it can be up to 3 days before they have enough of a viral load, even with a fever, before that PCR test actually comes back positive. So an initial negative result does not still rule it out. But at least it lends a little bit of reassurance that, we'll still do this, but we're going to wait 3 more days before we actually do and say nay. Yes?
So that timer starts at the point that they start showing symptoms. This is not something they can use for screening or anything like
The PCR test is not a good test for screening. Correct. Yes?
They said, and I've heard that viruses mutate.
Yes.
And they can also monitor people that is around or chances that it's going to mutate. How long does it usually take a virus before it starts mutating? Like at some point they're saying it's not everyone now, but eventually it could mutate and become.
How long it takes for a virus to mutate. This current strain of Ebola Zaire, that's currently being transmitted, it's not having the 90% mortality rate. Its mortality rate's closer to 55%. This current strain is 97% identical to the very first one that was discovered in 1976, as far as when they do the genome sequencing of it. So it's a little different, yes, but it's still 97%, and it's still acting like Ebola Zaire, except our mortality rate has not been so high. And I don't know if it's because it's less lethal, or maybe we're getting a little bit better care when we do get some care in there. I can't tell you, but it really is a virus that has been around for a while, since '76, and has not become an airborne thing unless you induce its airborne activity in a lab. They have not been able to actually identify airborne-related infectious nature to it outside of a lab. You guys know you can do anything in a lab, just about. You can make anything do anything. And so it's not that. And even the one with the Reston one that they thought that one was airborne. And I go, yeah, it's called handlers. It was, the handlers all had antibodies. So that means the handlers had the virus at one time. And so they were unfortunately spreading it from monkey to monkey. And then monkeys, I don't think monkeys are clean. I think they spit and they do all kinds of things in their cages and things fly in the air. So, but I don't think its likelihood of becoming airborne is also next to zero. I can't guarantee, but it realistically has always kind of shown this type of pattern of spread. And that's why, you have outbreaks. Because if it was more of an airborne type of thing, your outbreak would be very hard to contain with the current isolation procedures that they've done. So, yeah, it's mutating slowly. I'm not a virologist, I admit.
I would just add that if you look at its pattern of behavior, so for example, comparing it to flu as part of Ebola virus, the flu, every year constantly changing to different strains. Ebola has been very, very consistent. Even though there are slightly different strains, it's been very, very consistent throughout its entire life cycle. So its pattern of behavior doesn't really lend itself to thinking that it would mutate from airborne.
Yeah. Yes. Yeah, it's still recording. I forgot that I was still recording. Yeah, it's still recording, and I will make the link available on how to watch it. It'll be at YouTube. It'll be a long YouTube, but it'll be YouTube. Yes. Yes, Tina.
I heard or read something that if a care provider is taking care of an Ebola patient, they're assigned, that they should be either wearing institutional scrubs or throwaway scrubs under the stuff so that at the end of the day, they strip down and shower before.
You know what I think they should do? I think they should get a tanning bed. I was thinking, thinking outside of the box. I actually enjoy thinking outside of the box. And so I was thinking, at all those Ebola care facilities, they should have a tanning bed that's in that other room where they're stripping off all their clothing. So before, you can have UV lights to, inactivate it before you even go take your shower type of thing, Mm-hmm. Yeah. So, yeah. When somebody is highly contagious, when things are spewing from them, and they're circling the drain, that means viral load's really high. So anything that you do when somebody is that contagious, you should do as much as you can to protect yourself, I think realistically, with this type of a virus. And so having disposable scrubs and things like that's reasonable. But you have to understand, they have been treating it in West Africa without that luxury. And it is all about realizing everything that you have touched is, your hands are the biggest spreader of it. And so making sure your hands never come in contact with anything that could have been contagious or infectious, and getting that cleaned off before you start touching, I think that's the thing. And I just don't think people are really aware that they touch their face as many times in an hour as they do. And that's why I say these girls were perfect. I mean, I'm sorry, I don't mean to say it, mean it as a bad thing, but, you know, they had inadequate PPE on and inadequate understanding of what they were treating, and they went out with single gloves. Aren't you surprised that more people didn't get it when you actually think about it? And so what it was is they had all this contamination, but they touched themselves. I know that's what they did. That's how you spread it. You get to the mucous membranes. You know, I don't know, does any of them wear contacts for crying out loud? You know, think about the various ways that you touch yourself. Your earrings and things along that line, ear holes and stuff like that for putting your earrings on and stuff like that. That's the way it's spread, touching. And so that's why for us, it's not a big deal if you can just quit touching your face. So, you know, there's a story of one girl. She was taking care of 4 family members infected with Ebola. One of them died, 3 of them lived. She was taking, nursing students. But she was putting on, you know, garbage bags and things like that. She was covering herself up as much as she can. And I don't even think that she was having the face shield. I think she was just having mask, hat, and did she have stuff for her eyes? Yeah. But, you know, it was how she she acted like everything was infectious, and she treated it like that. And made sure she didn't touch those things, and she did. She didn't have to have throwaway clothes for herself and stuff like that, but she did do a very good job of taking care of her own hygiene. You know, I had another student. She works as a CNA at a nursing home, and they had a really bad GI bug, gastroenteritis bug in the nursing home, and it was going like wildfire through the nursing home. And whenever she went home, she made sure that she wasn't, she had her seat covered, she had her hands washed, she had cleaned herself as best as she can before she got home. And as soon as she got home, she got all of her gear off that she had been wearing at work, and she got undressed in the garage. You know, she got undressed in the garage and took it all to the laundry room and dumped it all in the washing machine and washed her hands again, and nobody in her home got sick. But, you know, that's good paranoid PPE. I think paranoid PPE should be better for you, you know, and using reasonable sense, because it's people just don't realize what they're doing. And I know that those ladies did not realize that. They thought they were doing the right thing, and they were, but they were young ladies that I saw long hair, you know, all the kind of stuff of what I know that you're going to do. And you tell me you're in a room and taking care of vomiting and diarrhea and all that stuff, and your hair's not going to get a little bit of something in it, you know. And they didn't have any hair nets on, hair bonnets at all. I'm just going, you know, I actually think that if they had been double gloved, had something on their feet and something on their hair, their chance of transmission to themselves would have actually been much less. And that's why the CDC guidelines weren't for, they had no hairnet in them, they had no booties, they just had eye, face, body, you know, a gown and some gloves, and not even double gloving. And I just go, you know, can't you even look at your own WHO algorithm for this? So, and that's where that actually occurred. Because can't you see how easy that would be, guys? You know, and just adding a few little things would have made all the difference in the world. But then what happens is people get paranoid, and then they overreact. But I'd rather, you know, Gina, I'd rather them overreact than underreact, which is what they were doing. And over time, as all things do, people get lax and lazy, right? Yeah, that's human nature. So, thank you guys for staying so long. I appreciate your attention, and I hope this was very helpful.